When you hear the word epidemic applied to HIV, you immediately think of virology, right? You think of immunology and infectious disease.
Yeah, absolutely. That's the classic sort of physical view of it.
Right. But what if treating the virus just isn't enough? I mean, what if the real driver of the HIV epidemic today is actually a psychiatric crisis?
Well, that completely changes how you approach the patient, doesn't it?
Spot on. So if you are joining us today, you are likely looking to build some, robust mental models around this exact tension. Our mission today is to do a deep dive into a conceptual synthesis of Kaplan and Sadok's comprehensive textbook of psychiatry.
Specifically looking at the neuropsychiatric aspects of HIV infection and AIDS.
Exactly. We're acting as a companion to your reading of the chapter, and the goal is to look past the surface of the diagnosis to really clarify those underlying mechanisms.
And to anchor this properly, I think we have to define what psychiatry fundamentally is. I mean, it is the study of how the brain, the mind, and the individual's lived experience interact.
Right.
But more importantly, it's the study of how that interaction breaks down. And HIV provides this stark, almost terrifying masterclass in that breakdown. It forces us to acknowledge that a systemic illness fundamentally reshapes mental function.
Yeah, the text introduces this really striking metaphor right out of the gate. It calls untreated HIV a war of attrition.
I love that phrase. It's very apt.
It is, isn't it? Because at first glance, you picture a physical invasion like a virus attacking T cells. But looking closely, it is an infection within the entire system that breaches the structural walls of cognition, emotion, and behavior.
Exactly, because the virus refuses to stay confined to the blood. It alters the very biological structures that govern how a patient thinks, how they process risk, and how they experience reality.
I've always heard it described as basically just an immunodeficiency issue, but reading through the chapter, it actually operates much more like a cellular Trojan horse.
That's a brilliant way to put it.
But how does it actually pull that off? Because, the brain is heavily fortified, isn't it? The blood-brain barrier is meant to stop exactly this sort of thing.
Well, that's the sinister part. It uses our own defenses against us. The virus hides inside macrophages, which are the exact immune cells whose job is to clean up debris and protect the system.
Oh, wow. So the guards are actually the smugglers?
Precisely. When these macrophages cross the blood-brain barrier to theoretically, help or monitor the central nervous system, they are actually smuggling the virus directly into the brain. It establishes a reservoir there very, very early in the infection.
Which means HIV is just as much a disease of the brain as it is a disease of the blood.
Yeah, the Trojan horse mechanism really forces a paradigm shift. If the virus is immediately infiltrating the structures that control behavior, you simply cannot separate the spread of the virus from the psychiatric vulnerabilities of the populations it affects.
So it's not just a viral epidemic anymore?
No, not at all. Some authors argue it's fundamentally a psychiatric epidemic. Psychiatric disorders play a determinative role in both the transmission of the virus and the failure of treatment.
Right, because we see these profound associations between underlying psychiatric conditions and increased risk behaviors for infection.
Exactly. These conditions create massive barriers to accessing care, and they are the primary driver of non-adherence to antiretroviral therapies, or RT. So the psychological makeup of the host often dictates the entire trajectory of the viral epidemic.
There is a concept in the text that perfectly illustrates this, actually, the unstable extrovert.
Ah, yes. The cluster B traits.
Right. So it refers to individuals with cluster B personality traits, antisocial, borderline narcissistic, histrionic. When you sit across from a patient with these traits, you are often looking at someone who is driven entirely by emotion and immediate reward.
They are deeply present-time oriented.
Exactly. So even if they have perfect intellectual knowledge of HIV risks, their psychological inability to tolerate negative emotions or, just boredom, it completely overrides tomorrow's consequences in favor of today's immediate gratification.
And that's the tragedy of it. Their present feelings dictate their entire reality. Educating a patient with that specific psychological architecture about viral transmission is largely ineffective.
Because they already know the risks.
Spot on. They know the risks. The issue is impulse control and emotional regulation. Which brings us to the vital concept of treatment as prevention across the HIV care continuum.
Right. So the ultimate clinical goal from the initial diagnosis to retaining them in care to prescribing the medication is viral suppression, because an undetectable viral load means the patient cannot transmit the virus to others.
Exactly. Undetectable equals untransmittable.
But we also have pre-exposure prophylaxis, right? pre-P, which prevents HIV infection if taken consistently before an exposure. I mean, that feels like it should be the silver bullet.
It is a revolutionary tool, without a doubt, but it have a glaring biological and social failure point. Vulnerable psychiatric populations, particularly those struggling with severe substance abuse or those cluster B personality disorders, often lack the executive function to access or consistently adhere to a daily PrEP regimen.
Right, so they just fall out of the care continuum entirely.
Exactly. So the psychiatrist's role is therefore not just ancillary or supportive, it is absolutely central. Treating the underlying psychiatric condition is a prerequisite for stopping the viral spread.
That makes total sense. Let's shift from the population level down to the microscopic level for a bit. I understand that the virus smuggles itself into the brain, but how exactly does it wage this war of attrition once it is inside the host?
Well, let's look at the virology. HIV is a lentivirus, which is a single-stranded RNA retrovirus. Now, the root lenti means slow, and early researchers mistakenly thought it was a slow-acting dormant virus.
But it's actually not slow at all, is it?
Not in the slightest. It is aggressively prolific. In a patient who is not on antiretroviral therapy, the virus manufactures roughly 10 billion viral particles every single day.
10 billion a day. That is staggering. And the human body is desperately mobilizing resources to fight back, churning out up to 2 billion CD4 cells daily just to keep the front line from collapsing.
Yeah, it is an exhausting, hypermetabolic battle. And on top of the sheer volume, reverse transcription, which is the process the virus uses to copy its genetic code, has a notoriously high error rate.
Which creates countless mutations, right?
Yeah.
So the immune system is constantly chasing a moving target.
Exactly. And it means the virus can rapidly develop resistance to our medications.
I always picture the viral life cycle like a hostile corporate takeover. The virus binds to the surface of the CD4 cell, specifically looking for the CD4 receptor and a co-receptor like CCR5.
That's a great analogy. It changes the locks, gets inside the factory, and unpacks its own equipment.
But here's where my mental model always sort of breaks down. How does an RNA virus actually force human DNA to manufacture its parts? That's the part that trips me up.
Right, so it brings its own specialized enzymes to rewrite the host's instruction manual. First, an enzyme called reverse transcriptase takes the viral RNA and transcribes it backward into DNA.
Okay, backward transcription.
Yes. Then a second enzyme, integrase, physically splices that new viral DNA into the host cell's own genome. At that point, the host cell has no choice.
So its own genetic machinery just reads the altered code and starts mass-producing viral proteins.
Spot on. And those proteins are then sliced into functional pieces by a third enzyme, protease.
And those specific enzymes, reverse transcriptase, integrase, protease, those are the exact targets we hit with our different classes of antiretroviral drugs.
Exactly. That's how RT disrupts the takeover.
Right. But taking this back to the brain, there is a mechanism in the text that completely upends how you might intuitively think about cognitive damage here. The virus causes all this profound dementia, but it doesn't even infect the neurons directly.
Yeah, this is a huge light bulb moment for a lot of clinicians. The virus selectively infects cells expressing the CD4 receptor, but neurons do not express CD4.
So what is it infecting in the brain?
It is solely infecting macrophages and microglia, which are the brain's resident immune cells.
Wait, so the neurons are just innocent bystanders getting caught in friendly fire?
Precisely. The cognitive decline is not caused by the virus bursting out of brain cells. It is caused by chronic neuroinflammation. The infected microglia act like rogue sentries,
Releasing a constant toxic cascade of cytokines and chemokines.
Exactly. The brain is effectively bathing in an inflammatory soup, which leads to abnormal neuronal pruning. The connections between neurons are literally stripped away.
And eventually, I imagine, the neurons undergo apoptosis, or programmed cell death, simply due to that toxic environment.
That's exactly it.
So if the brain is marinating in chronic neuroinflammation, how does that actually present clinically? Because it's not going to look like a textbook stroke with a focal deficit, is it?
No, not at all. It presents as a spectrum called HIV-associated neurocognitive disorder, or HAND.
Right, and that ranges in severity, doesn't it?
It does. At the mildest end, we see asymptomatic neurocognitive impairment, progressing to mild neurocognitive disorder, and eventually peaking at HIV-associated dementia, or HAND.
The text highlights a major historical shift here, which is fascinating. Before we had effective art, HIV dementia was this brutal, rapidly progressive subcortical dementia.
It was devastating. Patients presented with severe motor slowing, profound apathy, and a very quick downhill trajectory.
But today, we rarely see that severe end-stage HD, right?
We rarely see it because ART suppresses the viral load in the body, but, and this is crucial, ART does not fully eliminate the neuroinflammation in the brain.
Oh, I see. So while severe dementia is rare, the milder forms of hand remain stubbornly prevalent.
Massively prevalent. Large cohort studies, like the Cascade study, demonstrate that over 50% of some populations still experience cognitive impairment. And the clinical phenotype has changed.
How?
We don't just see subcortical slowing anymore. We see a mix of subcortical and cortical dysfunction.
Cortical dysfunction, meaning they present with prominent memory issues and executive function deficits. There's a specific term the chapter uses deficits in prospective memory.
Yes, prospective memory. That is the ability to remember, to hold a future intention in your mind.
Wow. Think about the clinical implication of losing prospective memory. If a patient cannot remember that they need to take their medication at 8 p.m., their adherence just plummets.
And then the virus rebounds, the inflammation worsens, and the cognitive decline accelerates. It is a devastating feedback loop.
Alongside those cognitive changes, we obviously have to look at mood. Major depression is 3 to 4 times more prevalent in HIV patients than in the general population.
It is remarkably common.
And we need to be very careful here to distinguish between a psychological reaction and a biological symptom, right? I mean, getting an HIV diagnosis is traumatizing, but this isn't just an adjustment disorder or demoralization, is it?
No, it is absolutely a direct biological manifestation of the disease. The chronic neuroinflammation, the cytokine release, and the direct viral injury to subcortical structures fundamentally alter neurotransmitter synthesis.
So depression in this context is often a direct neurotoxic effect.
Exactly. Furthermore, major depression acts as a biological vector for transmission. It drives isolation, exacerbates substance use, and destroys medication adherence.
Untreated depression actively fuels the viral epidemic.
Precisely.
The chapter also outlines a psychiatric presentation that sounds incredibly dangerous in a clinical setting. AIDS mania. It occurs in late-stage HIV, typically when the CD4 count drops below 200.
Yes, and what really stands out is that these patients frequently have absolutely no personal or family history of bipolar disorder.
Really? So a sudden manic episode in a patient with advanced immunosuppression and no prior psychiatric history
Is AIDS mania until proven otherwise. It is a consequence of advanced structural brain involvement. And it looks different from classic bipolar mania, too.
How does it differ clinically?
Instead of euphoria or infectious grandiosity, it is characterized by severe, brittle irritability and pronounced cognitive decline. The underlying dementia might actually mask the typical psychomotor agitation, making them look less hyperactive but far more unpredictable.
Let's turn that into a clinical challenge. Imagine a patient with a CD4 count under 200 comes into the clinic. No history of psychiatric issues, but suddenly they are irritable, manic, and they present with a very specific, dangerous delusion.
Let me guess.
Huh.
They are entirely convinced they have discovered the cure for HIV or that they themselves are completely cured.
Exactly that.
That grandiose delusion of being cured is a classic marker, and the danger is immediate. Believing they are cured, they abandon all precautions. They resume high-risk behaviors, spreading the virus to others while simultaneously exposing their own severely immunocompromised bodies to secondary infections.
Which perfectly transitions us into the hardest part of the job, integration and clinical reasoning. You are evaluating a patient experiencing systemic illness, neuroinflammation, and psychosocial trauma. All the signals are crossed.
It's incredibly complex.
Let's look at another clinical scenario. A patient with well-controlled HIV presents to your clinic with progressively worsening fatigue and insomnia. How do you differentiate if that fatigue is the virus replicating or something else entirely?
Well, this requires a suspension of assumptions. Studies demonstrate that in patients with controlled viral loads, worsening fatigue and insomnia correlate highly with worsening major depression, not with a declining CD4 count or HIV disease progression.
So nonspecific somatic symptoms like unexpected pain, dizziness, or fatigue should immediately trigger a comprehensive psychiatric evaluation.
Exactly. If you assume the fatigue is just the virus, you miss a highly treatable major depressive episode.
You also have to play detective with their medication list because the very drugs saving their lives can mimic psychiatric disorders. If a patient suddenly starts acting erratically, exhibiting severe depressive symptoms, or even frank psychosis, what antiretroviral class should you be hunting for on their chart?
You must look for the non-nucleoside reverse transcriptase inhibitors, or NNRTIs, specifically the drug efavirenz. Efavirenz. Why that one in particular?
It is notorious for penetrating the central nervous system and causing vivid nightmares, severe depression, and psychotic symptoms. You simply cannot treat that psychosis with an antipsychotic without first addressing the offending antiretroviral agent.
The pharmacology is just a constant tightrope walk.
Mm.
Let's go back to our patient with AIDS mania. My first instinct for acute mania might be to reach for a standard mood stabilizer like lithium. But based on the systemic issues in late-stage AIDS, that sounds like a trap.
It is a profound trap. Lithium is cleared renally. In advanced HIV, patients often develop HIV-associated nephropathy. If the kidneys cannot clear the drug, a standard dose rapidly becomes toxic.
Oh, right. And it causes other issues too, doesn't it?
Yes, lithium frequently causes gastrointestinal issues, polyuria leading to dehydration, and delirium. In an already compromised brain, you're essentially inducing a toxic delirium masquerading as a treatment. So you pivot to something like Depakote or valproic acid, which is generally better tolerated for the mania, but you trade a kidney problem for a liver problem.
Exactly. Valproic acid is heavily metabolized by the liver. Many late-stage HIV patients carry comorbid chronic viral hepatitis. Alternatively, they may suffer from systemic Mycobacterium avium complex or MAC infiltration.
And when MAC infiltrates the liver,
It causes portal hypertension and severe hepatic dysfunction. Giving valproic acid to a patient with MAC infiltration risks pushing them into fulminant hepatic failure. You must rigorously monitor liver function panels.
if that wasn't complex enough, when that CD4 count drops below 200, the differential diagnosis for altered mental status just bursts wide open. You aren't just looking at the virus or the medications anymore, you have to rule out opportunistic infections.
Because the immune system is offline, meaning the brain is suddenly vulnerable to invaders it would normally destroy without a second thought.
Right, toxoplasmosis is generally the primary concern here, isn't it?
Yes, it is an infection that forms abscesses in the brain. Clinically, it often presents with focal neurologic signs, perhaps weakness on one side of the body or a specific visual field deficit.
And if you order an MRI with contrast,
You will typically see multiple ring-enhancing lesions, heavily concentrated in the basal ganglia,
then you have cryptococcal meningitis.
which requires high clinical suspicion. A healthy patient with meningitis presents with classic meningeal signs: a stiff neck, severe photophobia, and a roaring fever.
But a severely immunocompromised patient can't mount a sufficient inflammatory response to cause that stiff neck, can they?
Exactly. They may just present with a low-grade fever and a subtle progressive delirium. You absolutely must perform a lumbar puncture and check the cerebrospinal fluid for the cryptococcal antigen.
The text also emphasizes progressive multifocal leukoencephalopathy, or PML. That is a demyelinating disease caused by the reactivation of the JC virus.
Yes, it strips the myelin off the nerves, leading to clumsiness, progressive weakness, and cognitive decline.
And finally, you have primary CNS lymphoma, the most common brain tumor seen in AIDS. Here is a diagnostic puzzle. Since both CNS lymphoma and toxoplasmosis can look like ring-enhancing lesions on a standard scan, how do you tell the difference without doing a brain biopsy?
You order a thallium SPECT scan. This is a crucial distinction based on cellular metabolism. Toxoplasmosis is a necrotic infection. It doesn't take up the radioactive thallium isotope.
But lymphoma is a tumor, so it's highly active.
Spot on. It takes up the isotope aggressively. A thallium SPECT scan is highly sensitive and specific for differentiating the two, allowing you to choose between initiating antimicrobial therapy or preparing for oncology.
Brilliant. Let's synthesize the core mental models we've built during this deep dive. HIV infiltrates the brain early via infected macrophages, creating a chronic state of neuroinflammation.
And while modern RT has largely eliminated rapid, severe subcortical dementia, subtler cognitive impairments like prospective memory deficits remain highly prevalent, directly sabotaging medication adherence.
We must also recognize that psychiatric manifestations like major depression and AIDS mania are direct biological consequences of the virus, not just psychological reactions to illness.
Exactly. The clinical presentation is an intricate web of direct neurotoxicity, treatment-related side effects, and life-threatening opportunistic infections.
Which brings us to the ultimate takeaway: integrated, multidisciplinary care. You cannot effectively treat the virology without treating the psychiatry. The mind and the body are not separate entities. A systemic illness reshapes mental function at a fundamental level.
As clinicians, we must approach every symptom with a broad differential. We cannot assume fatigue is just viral load. Nor can we assume psychosis is purely functional in a patient on complex antiretroviral regimens.
All right, let's quickly test our clinical reasoning with a few single best answer questions to lock this in. I'll ask the question, pause for a second, and then we'll get the answer. Question 1. What is the primary cellular mechanism by which HIV causes neuronal loss and cognitive decline?
The answer is that HIV does not infect neurons directly. It infects macrophages and microglia. This leads to neuroinflammation, cytokine release, and abnormal neuronal pruning.
Brilliant. Question 2. How has the clinical presentation of HIV-associated cognitive impairment shifted in the era of effective antiretroviral therapy?
It has shifted from a rapidly progressive subcortical dementia to a subtler mix of subcortical and cortical dysfunction, prominently featuring memory and executive function deficits.
Question 3. A patient with late-stage HIV with a CD4 under 200 and no prior psychiatric history presents with progressive cognitive decline, severe irritability, and the grandiose belief that they are cured of HIV. What is the most likely diagnosis?
That would be AIDS mania.
Spot on. Question 4. Which antiretroviral medication class, specifically the drug efavirenz, is notably associated with causing depressive symptoms and occasionally frank psychosis?
Non-nucleoside reverse transcriptase inhibitors, or NNRTIs.
Question 5. A patient with well-controlled HIV presents with worsening fatigue. According to clinical studies, this symptom is most highly correlated with what underlying factor?
Worsening major depression rather than a decline in CD4 count or HIV disease progression.
And finally, question 6. A severely immunocompromised patient presents with altered mental status and focal neurologic signs. MRI reveals multiple ring-enhancing lesions in the basal ganglia. What is the most likely opportunistic infection?
Toxoplasmosis.
Perfect. As we wrap up today, I want to leave you with a final thought to ponder. We started by looking at how this virus breaches the walls of cognition and behavior. We've seen how untreated depression, cluster B personality traits, and neurocognitive decline are primary vectors driving both the transmission of HIV and the failure of our best medical interventions.
It really makes you think about the big picture.
It does. So, could it be that the most potent, yet completely underfunded antiviral intervention we currently have isn't a new molecule in a lab at all, but rather robust, universally accessible psychiatric care?
It certainly forces us to reevaluate where we allocate our resources. Thank you for joining us as we explore these mechanisms. We highly encourage you to return to the textbook chapter to consolidate your learning.
Here are the details of this episode.
Neuropsychiatric aspects of HIV infection and AIDS. Byline: infection within the system. How a systemic illness reshapes brain, cognition, and experience.